All right, here we go in 3, 2, 1. What's up, y'all? Welcome to the Sports Medicine Broadcast, a podcast to promote and improve your practice as an athletic trainer. Today, Daniel Ruedeman shares what life as an athletic trainer in the Orthopedic Trauma Center is like. So Daniel is in Colorado, and we were just discussing some of the wildfires. And then also discussing the wildfires, we have Sandy Harris from the AT Corner podcast. So Sandy is joining me as a guest co-host. She told me she had an interest in emergency medicine, and I thought, man, talking with Daniel and orthopedic trauma and Sandy and emergency medicine, they kind of fit really well together. So I didn't really tell you this, Sandy, but Sandy, I want to give you an opportunity to give your elevator pitch for the AT Corner podcast. So I didn't prep you for this, so I just want to see what it is off the cuff. Ready, Sandy? All right, what is the elevator pitch for the AT Corner podcast?
So, AT Corner podcast, we actually started. My husband and I are fortunate enough to both be certified athletic trainers, which is super cool. So, we have lots of fun telling each other about our experience. And, we're both very different clinicians. But we actually, our podcast is a little bit twofold. So, we take every other episode is education or telling stories from athletic trainers and their experience, and we do different topics. So like when we're going to be doing like people's craziest mechanisms of injury that they've seen, or we're doing an episode on concussion stories, and then we also go into your traditional like interviews of athletic trainers and other healthcare professions that we come across in our profession. So it's been a lot of fun.
All right, so that you can check out on pretty much anywhere you catch podcasts. And I know they have a Facebook group too, so AT Corner Podcast. So it kind of does the ATC, the corner, and I think their email is atcornerds@gmail, something like that. So you kind of got it all going on right there with AT Corner. So if you search them up, or you can look in the show notes here, and I'll have a link to that there. This is Sports Medicine Broadcast. .com/orthopedic trauma. Again, sportsmedicinebroadcast.com/orthopedic trauma. So, Daniel, we are going to get right to you. And what does orthopedic trauma look like? So, start off with where you are right now, and then we'll kind of talk about where that goes. So, Daniel, welcome to the show.
Thanks, man. I appreciate it. It's an honor to be a part of your podcast and to meet you and Sandy and kind of explore this a little bit. It's kind of fun to be able to share these stories of kind of what I've been through and kind of what I do on a daily basis. So that's what I really wanted to come on and kind of just keep sharing that information. So I'm in Aurora, Colorado at the University of Colorado Hospital, or UC Health. Pretty big system here in Colorado. Been with the orthopedic trauma team for 6 years. Right now have 3 orthopedic trauma surgeons, 2 PAs, 2 nurse practitioners, and then there's a accumulation of 3 athletic trainers with these programs, and then accumulates limb restoration and osseointegration as well. So it's a pretty complex kind of setup here that we have, and then also have anywhere between 2 and 3 medical assistants that kind of help run the show. But I've been doing athletic training for almost 20 years, primarily in the physician practice setting. Obviously, I've covered a little bit of the PT setting and traditional high school setting. And it's something that I feel like it's my purpose. It's a fun, engaging experience that I get to have with my patients on a daily basis.
All right, so you mentioned limb restoration. I'm not quite sure. There was something else you said right after that, but limb restoration. What is limb restoration?
So lim restoration. So we have the limb restoration program here. It's ran by Dr. Jason Stoneback. Really works with patients that have non-union from of fracture, infections. We deal with amputations. Obviously, limb restoration, we want to try and prevent patients from having amputations, but it's a very complex orthopedic practice that he has going on here, very successful. And I kind of worked with him from kind of the start of that program 6 years ago, and kind of handed it off to a couple other athletic trainers. And then the other program that they're really pushing here at UC Health with his complex setting is osseointegration. And it's a pretty cool thing that's been going on kind of across the country a little bit, but mainly across the globe. But it's a very interactive way to really kind of help with patients deal with some complications with amputations.
All right. And so, Sandy, I know this is your first time co-hosting with me. So at any point, just feel free to go through the questions or continue asking whatever questions you have. And then I'll follow kind of you on that. So you guys were having a great conversation before we started, and you can just kind of continue with that. All right. So, Daniel, you've been in athletic training for about 20 years. So tell me, I think you said 6 years is how long you've been in the orthopedic trauma. Is that right?
Yeah, so I've been with the hospital setting here for 6 years, and it's been really awesome. I was working with mostly sports medicine, ACLs, rotator cuffs, things like that for a majority of my career. And I took a little stint off of the clinical side and became an office manager of a small private practice here in town, and kind of missed the clinical side of things and interacting a little bit more with our patients. So I knew the practice administrator here at the UC Health Hospital, and she brought me on and kind of helped me kind of open the floodgates a little bit. I was the first athletic trainer hired at this hospital, and then we ended up hiring 5 other athletic trainers to help cover some of those other subspecialties. But yeah, orthopedic trauma has kind of been a godsend for me, just because it helps me really connect with patients. One thing that I really try to push with my patients, I don't want them to just come here and have a doctor's visit. I want to make sure that they have a good experience. And have a goal that I reach every single day, that I've been working on for the last 3 years, is just making sure that I impact somebody's life in some way, whether it's on the phone, face to face, through an email, whatever. So I'd really try to connect and build relationships with my patients, because we definitely see them for a long time.
You said you were the first one hired as an athletic trainer?
At this hospital, they've had a couple athletic trainers operating, I think, on a little bit of a different role. But I was brought in and kind of was the pilot athletic trainer for this hospital setting. And I worked with orthopedic trauma, hand, foot and ankle. And so to me, it was kind of like, let me kind of show the skill set of what an athletic trainer can do in this setting. And then it kind of just exploded, and it's been kind of going since. So we have quite a few athletic trainers now. We've merged with some other clinics. So the ATC, or the athletic trainers that are kind of in this setting are getting better and better and better. We're getting higher volume. We have some openings right now for athletic trainers. So we still try to continue to promote what we do, how successful we are here, and how athletic trainers can play a pivotal role in the success of their clinics.
Was it difficult at first when you were the sole athletic trainer, or did they kind of already know what your role and scope was?
Not really, because they didn't really know what my roles could be. And so my approach to them is not saying, hey, here's what I can do for your practice. It's, what can I do for you? What do you need in your practice? And that's kind of how I sit back, I relax, kind of see what's going on, how they interact with patients. I'm a true believer of, saying the same things that my doctors say. So there's that continuity of care. No matter who they're talking to, they're going to hear the same information. But it was kind of, a little bit of a challenge working with some different subspecialties and different physicians that really hadn't had that connection with an athletic trainer before. But after a couple of months, it was kind of like, hey, each one of these subspecialties wanted to have a little piece of that. And it's kind of grown since then. So I think I was kind of blessed to have that kind of put on my shoulders by the practice administrator to kind of lead that, and kind of must have done something right, because we're still pretty successful in having these athletic trainers in the setting.
What was the transition like from the traditional setting?
That takes me back to when I was in Tennessee, and I'm like 2002, when I kind of just got started and working with a physician there, and it was just really shadowing and kind of getting a sense for what kind of role can we play in that. And at that time, I didn't know how pivotal we could be with answering questions, patient care. And that's really what I kind of thrive off of with the athletic trainers. Is we have a team approach here at the hospital, and that's what athletic trainers do. We operate as a team. So it's getting my medical assistant to be able to communicate the same as I do, or vice versa, and getting nursing staff to kind of see that same vision. So it's really kind of evolved over the years to really involve a team approach to this. It's not just the athletic trainer can do anything and everything. It's how can we complement other subspecialties, these other settings, and especially like with performing arts. It's all a team approach to that. It's not just the athletic trainer's involvement. And so I really try to get to know my team. And I think that was the toughest transition is there's turnover in staff, and it's just a mad, trying to work as congruently as we can to be able to say, hey, we're going to keep this party going. How do we do that? And it's building relationships, not with our patients, but with our staff. So I think that was probably the toughest thing is getting to know everybody and what everybody's roles can be.
Yeah, I can see how it can be difficult to, if you don't know what someone does, how can you pass along care?
Yeah. But it's the involvement of everybody, and it's our leadership really supports athletic trainers here. We've had a little bit of turnover in leadership, but everybody has kind of gotten on board and really supportive, from directorship all the way down to practice administrators, our nurse managers, our staff supervisors. So I think that's an important aspect of this with any role. So when I was at the high school setting, it was get the athletic director, to understand what kind of role I can play, how successful we can be, and making sure that we're communicating on the same level. And it's communicating with coaches at the traditional setting, communicating with coaches at the collegiate setting, communicating with, with the leadership and the people that are in charge with performing arts, the military setting. It's all about making sure we're all kind of on the same page and we have the same goals in mind. So it's pretty cool with regards to that. And when new staff come on, it's a different challenge. Like, how can we still have the same success, if not better success, with a new staff member?
Did you have a role in negotiating to bring on more athletic trainers?
So I think being the pilot, it was kind of interesting because, I'd had a relationship with the practice administrator for several years. And so she knew what athletic trainers could bring to this setting. And she really kind of helped steer that ship towards these other professions and had me kind of do some work with them. And so I think they just got a little taste of it. And it was just like, hey, how can I involve that and kind of continue to promote that? Other settings like oncology are kind of inquiring like, hey, how can you help with this type of setting? And there's athletic trainers out there that work in pediatric oncology that are super successful to be able to have that relation with kids and parents and that empathy side. And so to me, that was the thing is like, maybe I had this role of empathy. Maybe I had this personality that was kind of a catch, and they wanted to have a little piece of that. So we kept hiring athletic trainers. And I think it's a matter of just finding that perfect match that's going to continue to grow.
So you're in the Orthopedic Trauma Center right now?
So it's orthopedic trauma. Yeah. And it's a part of orthopedic in hand here at the hospital. But yeah, my sole position is going to be athletic trainer with the Orthopedic Trauma Center.
Were you in any other centers before you went to orthopedic trauma?
So I was an office manager at a private practice here. Learned a lot of different roles with regards to that, specifically like insurance, education, hiring and firing, different legalities, really kind of controlling DME, having a grip on kind of how that whole system works. But I'd worked at other small private clinics in Texas. I did my athletic training fellowship at the Steadman Hawkins Clinic in Vail, Colorado. And so that's another private clinic. So most of the time it's been a private clinic, but I did work at a hospital setting in New Hampshire, part of the Dartmouth Hitchcock system over there.
Did you say fellowship?
Yeah, so I did an athletic training fellowship in 2007 at the Steadman Hawkins Clinic up in Vail, Colorado.
What made you want to go into that?
Kind of goes back to my original story of kind of how I evolved as an athletic trainer. And I've only taken 2 athletic training classes in my whole career. I didn't go to an accredited athletic training program. Mine was the practicum route. So I did 1,800 hours in a year and a half. Thought I knew everything, took the test way too many times. Kind of a humbling experience to not know that stuff, but kept building myself up and working with a lot of great mentors. And one of my mentors was a guy that I met in New Hampshire. He was the actual director of the athletic training fellowship in Steadman Hawkins, came out to New Hampshire and kind of really helped steer that ship and kind of geared me towards that. So he helped me develop a post-operative program there, really develop our outreach program, but really kind of built the skills up of what I needed to do to be able to help be a successful athletic trainer in the clinical setting. And so he kind of opened that door for me, got an interview, and the rest is history. So I was very lucky and blessed to kind of have that kind of mentorship.
All right,
How
let me
long
jump
does
in
it-
real quick. So you
Go ahead.
mentioned the traditional or the old school route. That's what I did too. The internship, we did the
Yeah,
1,500 hours, and again, now everything is masters. You know, it's not no longer an entry level. Like here in Texas, we can still do the license entry level. You don't have to have the BOC, that kind and so it
correct.
still falls under that. But for the most part, having done that route and you've done the fellowship and you see where you are and you're seeing current or new athletic trainers, what's your real quick take on the internship route versus the master's athletic training?
Well, I mean, obviously, I think the curriculum for the master's program is much more detailed. I mean, there's things that they're doing now that I mean that I probably haven't even touched at this point in my career. So they're very very specific, goal oriented, curriculum based. Katie's got a really good grip on that, those standards. So it's really cool to kind of see those routes. Whereas for me, I went to a school that did. I was an architect major when I went to grad school, went to undergrad, and decided that to take this care and prevention of athletic training injuries or care and prevention of athletic injuries. And here I am 2 classes down and I'm like, all right, I'll take the test. And so not a huge fan of that, probably that practicum route, but I did get some really cool experiences working with different, professions, CSCSs, massage therapists. That was a part of the practicum route. You kind of had to shadow some other professionals. So I got to see that, but realistically, like I really got to push the master's route instead of the practicum route. But again, I wouldn't be here today without the experiences that I had. So
I gotcha. All right. So Sandy, I'm gonna go ahead and right here. I don't know where you're going. Like I said, I kind of interrupted there, but so we've talked a lot about how you got here, and we'll probably come back to that some more. But what does a normal day, week, month look like in the orthopedic trauma center?
so my Monday, it's actually really cool. I work 4/10, so I'm off on Tuesdays. Normal typical days a 7 to 5 day, and so I have a trauma attending surgery clinic, tendon surgery clinic on Mondays, and we have 40 patients on those days, and it's a 7 to 2 clinic day, kind of just all smashed into that little time frame, and it's just kind of go busy, which I like. I like that steady flow, that routine, and I work really well with my medical assistant, and we just kind of communicate. We kind of have a system down, and it's about communicating with our patients, communicating with our doctors. I'm ordering, bringing the patient back, ordering x-rays, taking a brief history. I don't do physical exams. Haven't done one in many years because it's an educational institution here. So I have PAs, fourth year medical residents, first year residents, med students that all kind of need that education too. So I just kind of prime the patient for what to expect in that visit. Let them kind of do their visit and then go in and answer any other questions, fill out paperwork, take care of things, schedule the next appointment, and help kind of plan that next adventure. So CTs, MRIs, whatever else is next, order physical therapy, develop a home exercise program. So a lot of the skills that athletic trainers have for any setting, they're utilized in this setting as well. But I think, you get to see pretty much the injury as it comes in, and as they kind of transition through their rehab, the surgeries, and kind of get to see them walk out. So one of the big milestones for me is seeing patients come in wheelchairs and crutches and walkers, and then the next visit they're walking in. And so it's just that progression of healing and rehab it's pretty awesome. Off on Tuesdays, Wednesdays, kind of my only half day of admin. And so I get a lot of paperwork done at that time. And then it's clinic the rest of the week. And so this week, today I have a tandem clinic. So I have a PA clinic and an attending clinic going on at the same time. And then tomorrow, kind of the same thing. So pretty high volume. And what's interesting with COVID, trauma doesn't stop. So we only really realistically missed 2 days of clinic throughout this whole process. Really been kind of strong with kind of where our precautions are, and been very successful here at the hospital. But yeah, trauma doesn't stop. So we kept having clinic.
You said that you help develop home exercise programs. Do you work alongside physical therapists for that?
Yeah. Yeah, so they'll send a lot of times the communication will be either through the electronic medical record system. We use Epic here. So they'll send messages through there, and I have some pretty good relationships with them. And so I think that's a big part of what I stand for with the position that I have. I really want to have good relationships with my X-ray techs, physical therapists, the PAs, the nurse practitioners, the nurses, the front desk staff. And so my personality is I like to joke, I like to have a good time, be positive, but really kind of have that open line of communication. If I see a PT walking down and she needs me, I'm going to stop what I'm doing, take care of the questions that she has, and kind of be able, again, it's all, we're here to take care of our patients. That's part of our mission and values here, is to impact patients' healthcare. So to me, it's a huge part of being successful as a team, is having that whole surrounding, kind of have an understanding. So I touch base with my X-ray tech every single day. Hey, here's what's coming in today. Give her a schedule and kind of lay out what the day looks like. But yeah, I definitely don't have a problem running down to physical therapy and asking for some guidance on some home exercise programs.
What kinds of injuries and medical conditions are you seeing? Are they more what you have seen in the traditional setting? Or are you seeing some stuff beyond what you've seen in the traditional setting?
Definitely beyond. So athletic training in this setting is, in the traditional setting, you see a lot of sports injuries, right? Ankle sprains, ACLs, shoulder sprains, AC separations. What I see are tib plateau fractures. So we in the trauma field pretty much see everything that's not spine related, not wrist or hand related, but tib plateaus, proximal humerus fractures, any long bone we're going to take care of. Had a night, basically gunshot wounds, unfortunately failed suicide attempts, people jumping off bridges, and you can kind of see the mechanism of injury. The bilateral calf fractures with a pelvic fracture kind of gives you the story. But you can kind of see different patterns, and that's what I really try to empower to a lot of the students that I kind of work with, is look at the X-ray, understand what you're looking at, but then start to understand how those fractures occurred, and then how are we going to treat those fractures. And so we see quite a few drastic things: motorcycle accidents, car accidents, auto ped injuries, to the elderly falling on just a ground level fall and fracturing their hips. So we'll do hemiarthroplasty, so partial hip replacements. We don't do total hip replacements, but a lot of femoral neck injuries to pelvic injuries, and some really cool surgical techniques that I've never seen before I get to be a part of. So.
You said you're part of surgery?
So I have not seen, I used to scrub in when I was a part of a sports medicine team, but here there's just so many people involved that I don't get a chance to be a part of the surgery, but I help take care of almost all of the post-operative patients.
Oh, awesome.
All right, so you've been part of secondary school, you've been part of college athletics, you've been part of the private practice setting, you've been in a university setting with your current job. So tell me some of the things that you like about each of those settings, and then why you've chosen the orthopedic trauma setting.
So, I mean, realistically, I think, starting out with the high school setting in Tennessee, it was a private high school, kind of scared out of my mind to kind of be out on my own and kind of do all that stuff, make those decisions, send those patients for referrals, PTs. But it was kind of like, that's kind of how I learned. And you had some difficult coaches, didn't understand my role, kind of slowly built that relation back up, dealing with parents, communicating with parents effectively to be able to say, hey, here's how your son or daughter's doing. Here's the injury they have. Here's the plan of care. To the college setting. And when I was in Lubbock, I was the liaison to Lubbock Sports Medicine and Texas Tech Athletics. And so I got to set up injury clinics for the football athletes on Wednesdays, and then on Sunday afternoons after their Saturday competitions. So I got to be a part of that. And again, it's just fun to be able to be a part of athletes, their injuries, communicating with the team to be able to kind of say, okay, how are we going to handle and manage these things, building relationships, to the private practice where it's doctor ran. And so there's a lot of directives, a lot of patients and doctors have to reach certain numbers. And as you start to evolve as athletic trainers, you have to start to understand the bigger picture of the business side of things versus just treating the patients and the athletes. And then coming over to the hospital side, third-party reimbursement's not huge here, so we can't bill for certain services, whereas private setting you can. So there's different things, but again, it's all coming down to the patient care, the athlete care, communicating with patients. I always tell my students, like, if you can communicate with a doctor, you can share the information. I think communicating with mom and dad is going to be a lot easier, and you just have that confidence to be able to have that information, to be able to share it. So to me, it's been a fun process to watch how I've evolved over the years, and how much easier it is to be able to talk to people, have a good time, joke, even when there's a serious injury going on, just to be able to lighten the mood a little bit.
So you mentioned your schedule. Why is Tuesday your off day? It seems like normally it'd be like a Monday or a Friday.
So I used to, when I first started this, that was one of the key things, was like, man, is having a 4-10 shift. That's pretty sweet. There's not too many athletic trainers across the country or even across the world that have that kind of a shift opportunity. So that's one thing I value my day off. Pretty valuable. I mean, it's one of those things that I can get a lot done, take care of myself, get some things done for my kids. So it's pretty powerful for that. With regards to, Tuesday. So when I first started, I had Wednesdays off. We didn't have a clinic on Wednesday when we first started this. And so that's the day that I decided to take off. And then I transitioned to Fridays. We again kind of transitioned. We did have a Friday clinic. We had some staff changes, so we moved that. And our limb restoration and OI team were kind of in a bind of like, okay, we've got a lot of things going on. We just don't have the manpower to get a lot of these things done. So I just kind of proposed to him, and I was just like, hey, listen, I don't need my Fridays off. If I come in on Tuesday, there's a Tuesday clinic, if I take Tuesdays off instead of Fridays, like if I switch that up a little bit, will that help you guys out? And so I just kind of took one for the team and kind of just switched things a little bit, and kind of, we didn't have to hire an extra person. By me switching a day off, freed up somebody to be able to work a little bit more admin related on a Friday. And to be honest with you, yeah, it's a little tough coming in on Monday, taking a break, and then having another 3 days, but I wouldn't change it right now. It's actually pretty cool.
All right. And then we were talking beforehand. I'm sorry, go ahead, Sandy. Go ahead.
I was just going to go into the next. We just talked about what you do love. Are there any parts that you don't love about your job?
I think as things transition, it's building relationships and how to keep those relationships going. And there have been some times where it hasn't been the easiest to communicate with physicians. Work-life balance was always a struggle, and I really don't think that really hit me until probably about 4 or 5 years ago, of how important work-life balance really is. And so, again, I value that day off to be able to take care of myself, to get things done that I just don't have time during the week. So I think, as we start to navigate, and I think that's one thing that I really push with my students is, when you're not here, go take care of yourself. Do the things that you need to do. Don't take work home with you. I did that for a majority of my career. I worked long hours because I thought I needed to, because I thought that's what was expected of me. But having that work-life balance transition to where I'm at right now, my evaluations are the best that they have been. I'm a much happier person, much more positive. But when I leave here, I don't take work home with me. And so it's kind of nice to be able to make that transition. But, there's certain personalities out there that sometimes you clash, and it's just kind of, again, navigating that a little bit and learning to adapt and controlling how you can react to situations.
Sandy, let me ask you something while we have Daniel here. He's talking about life balance. What does that look like for you as a new young professional? I think you said you've been certified for 1, maybe 2 years. What does that look like for you right now?
Randy and I always joke about this because we're both certified athletic trainers. So we go to work as a certified athletic trainer. We come home to certified athletic trainers, and now we have an athletic training podcast. So really, where is that work-life balance? So for me, it is definitely knowing As I go into what I'm looking into going into the community college setting, because I know that at the community college setting, I can still have my athletic training hours, but they're a little bit, the hours are more protected. And I know that I'm still doing what I love at work. And then coming home, I know that with um, Randy and I always make sure that we have stuff outside of athletic training that we look forward to. So we make sure, like, we have a German Shepherd that we love. And so just coming home and, she's like our dog child. So, doing things for her, stuff that takes life off, uh, your mind off of athletic training, which is pretty much all the time for us.
Do you find it's kind of a tough transition to do that, to come home, and do you have an opportunity to decompress on your way home? So when you get home, you don't have work on your mind per se?
So where we actually just moved, we moved 2 hours away from home, and then we just moved just back to our home county. So where we were working previously, our commutes were at least an hour, which the drive was beautiful. We were living in the mountains and we loved it, but it was, I've never been a huge commuter. Randy always has been, but um, it was actually nice, that mountain drive just on our way home. It was a nice way to decompress. Even though it was long, it was a nice way to transition from work back home.
Yeah. That's what I love. I love my drive home to listen to music, podcasts, motivational talks, kind of catch up with people. That's kind of my opportunity to be able to do that, because when I get home, it's like you still have life to do at home, and it's like how do you balance all that? How do you get to bed on time? How do you wake up on time? But it's, to me, that's one of the fun things, is being that it's orthopedic trauma. I don't know what I'm going to receive on a daily basis. I kind of have an idea, but you really don't know until they show up. So that's the exciting part. I wake up and I'm excited to go for the day. But it's kind of nice on Monday. I get to call home. I can stay up a little bit later because Tuesday I don't have to work. So it's kind of a nice little balance. And that day off, again, it provides a lot of time for myself.
For your setting, when I know, like, in the traditional setting, we have, let's say we're open until 6, but if someone walks in right before 6 and you take them and you're working with them, you might get out a lot later than you anticipated. Does that happen a lot with you guys, or usually, like, let's say you get off at 6 p.m., is that usually pretty true?
So, I mean, most of the clinics, like especially for my trauma clinics, it's either our last patient scheduled at 2:30 or 3:30. So we have a little bit of that grace period before 5 to be able to get some things done. If I'm not picking up my girls after school and stuff like that, then I'll stay a little bit later to kind of make sure that I have my hours. So there are days where, like last night, I left at 6:30. There's certain days I'll leave at 5 or 4:30. It just kind of depends on the day, the nature of kind of where triages are at, phone calls are at, messages are at, and stuff like that. And with COVID here, it was kind of interesting. I've been salary most of my career, 99% of it. And as of 2 months ago, they did change me to hourly. So I definitely have to keep an eye on kind of when I get here and when I leave, and keep track of those hours. But that allows me that if I do stay late and work a little bit extra on certain days, then on Friday I can leave early. So again, a little bit of balance with that.
So kind of along those lines, is there, without too much specific details, is that normal for an AT in the physician practice to be hourly? I would think I would imagine it would be salary, but is that normal? And then why did they make that switch?
It was interesting because, again, all of my career, it's been salary, and no one wanted to pay us hourlies because, consider, work in the high school setting, there's some of us that work 80 to 100 hours a week to be able to get things done. And no business wants to really pay that overtime aspect. The reason there was that switch was COVID. And so I was furloughed 20%, which accumulated to 2 days and 2 weeks off of, I think back in April or May. And then in May, they made the decision that come July or August, you're going to get furloughed again. So plan on taking some time off. So I had just happened to plan some time off. But again, with trauma, our clinics were pretty steady. I mean, we had some days where we only had 7 patients all day, when people just didn't want to come to the hospital. But as we started to pick up volume in clinics, that's when they were going to consider furloughing more staff. And in order to be able to keep us on staff in the sense of not being furloughed, they made the decision to switch us to hourly because all salaried employees were being furloughed. And our doctors kind of were like, nope, don't take my staff away from us. So then they made that switch to hourly. So it's been probably 2 months of hourly. It's just kind of interesting because, yeah, you got to keep track of your time when you clock in. There's certain ways to strategize all that stuff too.
It's very, very interesting. Yeah, because obviously here at the high school, the only time we've had to watch our time was, like I said, the first 4 weeks of this year, whenever there's no students. You're supposed to be here for 8 hours or whatever. But even at that, if I'm here 10 hours on Tuesday, well, then I'm going to leave 2 hours earlier or 4 hours earlier or whatever it is. So it's interesting. I just don't have as much flexibility to do that.
Yeah. And that's one thing I really liked about the high school I worked at in New Hampshire. It was kind of like, if you work over, we owe you. If you work under, you owe us. And that was kind of the relationship we had for the years that I was there. And it helps build continuity, good relationships with the company and the staff and your supervisors, if you keep a good grip on that. But again, athletic trainers, we need to have time management skills as well.
All right. And so, again, as we have Sandy here, she's married to an athletic trainer, having a family with 2 athletic trainers, and you are a father. You got 2 girls, and you see a lot of female athletic trainers transition out of athletic training due to raising a family, right? So is this something that you think is a good fit for a family, the physician practice? Do you think this is like a good possibility for an athletic trainer who wants to be highly involved with their family, things like that?
I think, that was one of the big switches for me, being in this setting. Was I don't have to work weekends. I'm not traveling, and having Fridays off. It allowed me to have the opportunity to travel. I could leave a Thursday night, go somewhere, leave Friday, come back on Monday morning, go right to work. So there was a lot of flexibility. I'm a divorcee, but my co-parent and I mean, we have kind of one of the best relationships I could ask for. We're better friends now than we were when we were married, and the communication is just on point. And that allows for us to have some flexibility with our kiddos. And when I have to pick them up from school, I leave at 4:30. So I manage that side of things. When I need to leave to take care of my kids, I'm done. I go. When I don't have to get my kids, then I'll stay late and make up that time. I think, again, having that work-life balance, and again, it just really kind of just clicked into me about 4 or 5 years ago, like, oh, wow, this is truly important. I don't want to miss stuff. I'm going to miss stuff at some point. I've missed some dentist appointments. I've missed some parent-teacher conferences. Now things are on, virtual, so it's a lot easier. But I think as long as you have a good idea of kind of how to manage that time and what it is that you can do to take care of yourself, whether you're a mother or a father, if you're just a parent in general, I think there's definitely opportunities to be super successful at your work and at being a parent, as long as you plan accordingly. And I think that takes time. I think that takes a lot of practice, a lot of, failures, but, whatever works for that individual.
Right. You mentioned the relationships, there's constant relationship, and then obviously athletic trainers in the secondary setting, we know, I've got this kid, she's been with me freshman, sophomore, junior, now she's a senior, now she has an injury. And so I've been taking care of her, and now like we have this, I guess, long-standing, almost daily relationship. And then you said you'll see a patient come in on the wheelchair, and then the next time they're walking, those kind of things. So talk to me a little bit about some of the solid relationships that you've been able to form with patients, even in the physician practice setting.
So it was interesting, and it's kind of ironic because one of my favorite patients, probably not a good thing to say that, but that's one of my favorite patients, came in yesterday and to see one of the other physicians. So I'll do some talks across the country with other athletic training programs to kind of promote this kind of unique orthopedic trauma setting that I'm in. But I told him yesterday, I'm like, dude, you were kind of the focus of my talks. You start off my talk and I end with you. He was in a horrific accident 5 years ago, 17 different fractures. I was there the day that he ended up he was actually able to stand for the first time. And we actually talked and laughed about it yesterday. He's like, yeah, I told you not to let go and you didn't let go. And so that picture is a part of my talk. And it's, to me, it's like, that's kind of one of my pivotal moments of like having a good established trusting relationship with your patients. Like he trusted me to hold him up for the first time, being able to put weight on his legs when he hadn't been putting weight on it for almost 3 months. So seeing him yesterday, it was a good opportunity to be able to kind of just catch up. He's got 2 girls, and one of his little baby, who's now 5, was in the bad car accident, and his wife was in the bad car accident, and everybody's okay. And it's just kind of cool to see him come back. He obviously, if he's coming back, he's still got some issues going on, which we knew about, but having a good solid relationship, to see him walking down the hall and he turned around and say, I want to see you. And can't hug right now, but if we could, we'd be hugging each other. But it's just a good relationship. But that's what I look for, is to see those patients come in. And I saw a patient yesterday. She was like, oh my gosh, I saw you 3 months ago, you didn't have tattoos, and now you have tattoos. And they noticed those things about it. And that's what I'm saying is, like, no matter what setting you're in the performing arts, you're in the high school setting, you can develop those relationships, not only with the athletes, but also the coaches and the parents. And I just think that makes work-life balance so much easier. But yeah, I definitely take pride in having a personality to be able to attract some good relationships with my patients.
And then, so in the physician practice and the clinical setting, you usually I would think, and working closely with physical therapy, you'd probably have a different budget than we would here at the high school. And so some of the cool tools, we got like the Compex boots or the Compex units for the muscle firing, or the Mark Pro for that kind of thing. So what are some of the cool tools that you've seen working in the physician practice setting?
So I don't really have tools. So what I can relate to are the different types of surgeries and the different type of procedures that are done with regards to that. So obviously, if you're around, I think what everybody kind of has an idea, if you're around athletics right now, is the quarterback for the Washington Redskins, who had that horrific accident, fracture last year, and was in one of those ring fixators. We call them Taylor spatial frames. Those are the things that I used to, when I was with limb restoration, I dealt with those on a daily basis. And they can really kind of, when they're on your leg, they can help lengthen the leg, shorten the leg, work on torsion, twisting, rotation, tilting, to try and get that weight bearing access, that alignment in a better position. There's certain types of procedures of the pelvis where you can have an external fixator of the pelvis, meaning the pins are hanging out, exposed around your pelvis. Well, one of my surgeons does an infix, an interior fixation. So there's a rod going across your pelvis, just inside your skin. And to be able to communicate with patients on how they're going to progress through the rehab with this pin inside them. And just the different ways that our trauma surgeons kind of fix things. We've actually had this kind of weird number of scapula fractures coming in, and for a majority of my career I've probably seen 1 or 2, and for this last 2 or 3 weeks I've seen 5 or 6, and 3 of them have been surgical. And I, being in this profession as long as I haven't seen a scapula fixation before, and how to put a plate on a scapula and how to have the bone purchased to be able to do that. And there's company with a clavicle fracture associated with it most of the time. So it's pretty cool to see my trauma surgeons. I tell them, we deal with woodworking, we deal with puzzles, and they're experts at putting puzzle pieces back together. So those are the cool tools for me. We deal with DME and stuff like that, which there's not a whole lot of excitement with some of these braces because they've been around for a long time. But those are my cool tools, is to see those types of surgeries and how I can help patients through them.
Sandy, have you been in surgery observations at all?
I've done a few.
So what are some of the ones that you've seen?
We had a lower leg specialist and a foot ankle specialist at a nearby surgery center that I've gotten to observe, but I've seen mostly ACL and rotator cuff.
I think the first one that I saw was a clavicle fracture, where they put the metal plate there on the clavicle. And, I've thought before maybe it'd be cool to work in the physician practice, that kind of thing. But if you go into surgery, that's really tough because you smell that burning flesh. It's
Yeah.
it's tough. It's tough to handle. I always have to walk out every time I go to a surgery. I go in there knowing, okay, I'm gonna go in there and then I'm gonna have to walk out, catch my breath, come back in, right? I may have to sit down or lean against the wall just because I don't know something about it, but it's really cool because I've seen clavicles or ACL or MPFL, and just recently my father-in-law had his knee replaced, and the doctor's like, you can come. It's pretty gruesome and bloody and long, and I know you get kind of weak. So I was like, you know what? I'm gonna go ahead and skip out on this one. But it was pretty cool to know that he was gonna allow me to, and I could have, like you said, get to see that stuff. But yeah, I don't think I would have done too well.
I got a couple of things with that. So I having two girls, obviously, like tubes in their ears and stuff, and I thought I was going to be, the strong dad and take my daughter back to surgery for her first surgery on her tubes, and laying her on the table and they're giving her gas and she's screaming for your name. That's not the easiest thing. So I don't advise people going and watching their siblings, kids, moms and dads have surgeries. But I'll never forget the very first surgery that I ever watched, and it was non-orthopedic, and it was in Tennessee. And one of the football players, he was one of our kickers. His dad was a urologist, and he saw me in the surgery center. I was getting ready to watch a total hip. That was my first orthopedic surgery that I got to observe. And that's pretty cool in itself to see the hip get dislocated manually. But the first surgery I saw was a bladder resection. And here I am, the guy's, in his mid 70s, his head's between my legs. I'm standing right near anesthesia, and then the whole abdomen's open and the bladder's been taken out. And it's interesting to kind of see how things, you think you have an idea what an intestine looks like until you actually see it. And when he was putting everything back in, I was like, dude, do you need to have a map of where everything goes? And he's like, no, you put it back and the body will naturally do its thing to get it back where it needs to go. And so my first surgery, I'll always remember as a bladder resection. And to me, orthopedic wise, that's, I've been a part of meniscus repairs, ACLs, rotator cuffs, got to be able to hold an instrument and kind of feel what the acromion feels like when you're actually burring it. It's actually a pretty cool experience to be a part of that. And then to be able to suture up incisions, is pretty cool. And that was one of my goals. I wanted to be able to scrub in, got to be able to scrub in on those surgeries. And I think when you're in surgery, you get to have a different appreciation for, you get to see what the meniscus really looks like. You get to see what the rotator cuff really looks like, what an ACL graft being prepared looks like. And I always encourage my students, I haven't seen a trauma surgery since I've been here. I can picture them in my mind. But every student that I have that comes and shadows me for a clinical immersion, they'll get to have an opportunity to go and watch the trauma surgery, and kind of the trauma surgery of their choice. It could be as, elementary as a Achilles repair to, a pubic symphysis, open reduction, internal fixation, to open pilon fracture. So we get to see quite a few things, and I'll open the doors to as many people as I can to come and shadow us and get an experience.
So you mentioned that you've done talks across the country. You're working with Katie. You're working with COPA, and so I know I listened to Joel in his podcast with Mark, and he said that since he's teaching, he feels like and he's not doing athletic training at all. He feels like that the best thing he can do is serve full time. That sounds kind of like what you're doing. You're not doing all the extra hours. You're doing your 40 hours, but then you're being involved elsewhere. So if someone wants to catch one of those talks or find out more about the physician practice setting, what's some of the best resources, some of the places you might point them?
So you guys, I attached my email to your notes, so you guys can definitely reach out to me, to my email. And I think, what I try to encourage people to do is to be able to give back. And because of where I started in athletic training, and I kind of fell to the bottom, not being prepared for what I thought I was prepared for, and the people that helped build me up, my mentors. So that's my whole philosophy, is to be able to give back. So that's why I think a lot of our, athletic training, we build off of everything that we do based off of our relationships. It's who you know. And so going across the country, it's about knowing program directors, being a part of the Athletic Trainer and Physician Practice Society, and going to those meetings and networking and people understanding like, oh, you work in trauma, what does that mean? And so I'm like, well, hey, if you want, I'll do a talk for your students and kind of just open their eyes a little bit, because I don't think a whole lot of athletic trainers understand that there's a ton of different opportunities out there, not just high school, not just college, performing arts, military, industrial. I was fortunate, I got to have a little bit of taste of the industrial setting in Tennessee, and it's pretty cool. So there's different opportunities out there. And I just want to be able to say, hey, my door's open. If you want to come and see what this world's like, reach out to me. I'm doing some talks in Indiana for a couple of places coming up. I've been in Kentucky. I've done some talks for Boston University. And then I'll do the local ones for Colorado Athletic Trainers Society, Rocky Mountain Athletic Trainers Society, and just kind of continue to promote what this different setting looks like. And then being with COPA, Committee on Practice Advancement, and being a part of the Physician Practice Society, portion of that. We have a good group of people that do that. So I think just getting involved, asking questions, and I think that's what I really want to continue to push our young athletic trainers to do, is just to ask questions.
So somebody like me, I'm almost 40. I'm 39. This is my 17th year working in the high school. I want to transition to industrial setting or physician practice setting. So that I can create more life balance, but I'm afraid to make that jump because this is what I know. Obviously I have a wife and four 3 kids and a foster baby, so 4 kids. What would you say to me if I'm wanting to but afraid to make that jump?
I think reach out to your resources. So when it comes to industrial, a lot of physical therapists may have connections to industries that kind of have that need. They're seeing a lot of injuries coming from those. So I think that's where I kind of started out, was just like reaching out, like, hey, I want to shadow that orthopedic surgeon. Can I just go and watch him in clinic? And I shadowed Dr. Paul Thomas at the Bone and Joint Clinic in Franklin, Tennessee. That was my first kind of experience to an orthopedic trauma or just orthopedic setting. And I still stay in touch with that man, and he's still an influential person in my life. So it's just reaching out and saying, I want to look into that setting and I want to see what it's like. When I became an office manager, I had no experience being an office manager. Had I experienced, quote unquote, being a leader? Yeah, I think as athletic trainers, when we're the athletic trainer at a high school setting, we're a leader because we're directing a lot of things, a lot of moving parts. Same thing with Sandy. Like when you're the athletic trainer of performing arts, like, you're there, you're kind of in charge of kind of like, can this athlete go, can this athlete perform? You're in a leadership type of role in that position. And I just asked questions and I just said, hey, can I? And I sent out an application to an orthopedic clinic that I didn't know that they were looking for an opportunity for a management, and I got a phone call out of it. And so I've reached out. When I was younger, I reached out to the Denver Nuggets, the Colorado Rockies, the Denver Broncos. Those were the teams that, everybody wanted to be a part of. And nothing transpired. So I worked at an athletic club in Colorado, but that still opened doors for me. That still opened doors for experience working with a personal trainer that works with the Broncos. So I got to see kind of how different things work. And to me, I was blessed to be able to just kind of see a bunch of different settings. So I don't write in my opinion, it's like, no matter what age you are, if you're male or female, if there's something that inspires you, I think just ask, see what people say, especially with athletic training. Someone's going to know somebody or something or some place that's looking, that's interested, that say, hey, why don't you reach out to them and see what they have? And all of a sudden doors are just going to start opening.
I know that some athletic trainers have an OTC credential or certificate. Do you have one of those, or do you know athletic trainers who have those that are beneficial in your setting?
So I did have the OTC certificate. I had it when I was in Texas up until basically I moved to Colorado in 2012. I let it expire because it just wasn't beneficial to me. I know that's kind of that talk out there is these, specialty certifications. I think when it comes to investigating and looking into that, I think you need to look at, how's that going to benefit me? Does the hospital, does the practice, does the employer recognize it? Can we get it credentialed in a sense? So for my aspect, if I'm becoming an OTC, am I using it more for the casting aspect or the surgical aspect here at the hospital? the surgical aspect may not be beneficial to me because I think it would be harder for me to really get in and actually scrub and perform surgeries with the physicians. Whereas I can utilize that service as a cast tech. Whereas, do I need that now when I have so much experience that I can move forward with that? I let it expire because it wasn't beneficial to me, but I think there's opportunities for other athletic trainers to look into those. And I know the NATA is pushing a little bit with these, these specialty certifications. I think it just has to be one of those situations where you have to evaluate kind of the whole circle. Is it truly beneficial to me? Whereas with the OTC, when you submit CEUs, it's 120 CEUs over 6 years, but not every CEU that you obtain through the NATA can be transferred over. And then you have to pay per CEU to be able to submit those. So does the cost outweigh the benefit? Does the benefit outweigh the cost? So I think when it comes to those situations, doing a little research, doing a little bit of legwork on those will be beneficial because each state, each institution recognizes things differently.
All right. It is, I want to be respectful of your time. It's kind of right there about the end. Sandy, do you have other questions, specifically orthopedic trauma or physician practice related for Daniel?
That was my last one.
Your last one? Fantastic. All right. And so, Sandy, I am glad that you were able to join us and share some of your thoughts and questions. Daniel, I really appreciate the wisdom and the advice. Again, talking about the life balance, the find what works for you, try all the different experiences. And then if you want to reach out, then you can check out the athletic trainer physician practice setting or COPA, or you can email Daniel, which I have in here, or on social media. He's Thunder Dan ATC. So where does that come from?
So I was a huge fan of Dan Marley back in the day, and so when I was playing high school basketball, I think it was a freshman or sophomore, and this 7-foot basketball phenom, was like, "Hey, I'm going to start calling you Thunder Dan because all you want to do is shoot threes." So Dan Marley was kind of my kind of that guy that you looked up to for the Phoenix Suns playing basketball, and it's just kind of stuck, and that's kind of been my handle for a long time. So I've just kind of let it go. And when my kids were growing up and learning my name, they actually just started calling me Thunder Dan instead of Dan or Dad. So that kind of just stuck.
All right. It is definitely interesting to hear your kids call you Thunder Dan instead of Dad.
Yeah.
My former coworker, his name was Bill Doc Hale. He was the first athletic trainer here in Pasadena ISD. And so like his wife and kids, or her kids, he remarried too kind of thing, but they would call him Doc rather than Bill or Hale or anything like that. They just called him Doc because that was what everybody called him. That's what stuck. So
yep, and he's a well-known guy. I know him, and it's one of those things where it's like those people kind of stand out and kind of have that name for a reason, and he's earned it. So, yeah, definitely love nicknames and stuff like that. So it's one of those things that it's kind of funny when people bring that up. Why do we call you Thunder Dan? And I'm like, no, I'll tell you the story.
All right, so Thunder Dan on Twitter. If you're on Facebook, you can look for Daniel. It's RUEDEMAN. You can look for Daniel Ruedeman, or again, if you're looking at sportsmedicinebroadcast.com/orthopedic trauma, I have a link to those. Sandy, the best way to get a hold of you, usually Instagram, right?
Yeah, Instagram, it's really easy. Sandra the ATC, and that's also my Gmail, sandratheatc@gmail.com.
All right, so you can get a hold of Sandy there, or the AT Corner podcast. Again, if you search for it anywhere, you'll find it. I did a Google search, and then Google's pretty cool. It comes up with the actual podcast, like episodes right there is like the number 2 option. So you can find that there. If you want to reach out to them. I know recently, I think episode 8, I was on there talking about some of the weather stories I've had. And then as she was talking about some of the stuff that they have coming up, it's interesting. Like, oh yeah, I could share about that too. So like we had a soccer girl who fractured her femur when she was by herself. So she just went to turn and kick the ball and boom, fractured the femur right there. Practice. It was like in May. So it was like end of the school year. So boom, now she has a rod in her legs. Oh yeah, just craziness, right? So wow. It's really cool because they do share your stories on the A2 Corner podcast. So reach out to Sandy or Randy, and maybe you can share some of your stories or just check them out. And again, if you want to be part of the physician practice setting, reach out to Daniel. Like you said, he does talks across the country. If you're in a high school setting and you want to expose your students to different opportunities, hit him up. He can jump on a Zoom call super easy. or if you're in a college, or even if you're in like a career transition setting, something like that, speak to somebody who's been in there. So again, I have his email in there, and Sandy, Jeremy. So I mentioned some of the cool tools earlier. So like if you're using Mark Pro, you can use the code TheSMB. If you're going with Myotech, you can use the code TheSMB. If you're using Hoist Hydration, again, I like it far better than Gatorade or any of the other Powerades, anything like that. Again, using TheSMB as a promo code, all those that'll help save you some money, get you some free stuff or something like that. So for Jeremy, Daniel Ruedeman, Sandy Harris from the AG Corner podcast, in the sports medicine broadcast, that is a wrap. Thanks.
Thank you.